The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead.
Welcome to Project Independence and You.
Good morning and welcome to Project Independence and You, community talk radio on 88.1 FM and WCWP.org. I am your host, Rebecca Miller, along with our co-host, Otto Lohse. Good morning, Otto. How are you?
Good morning, Rebecca. It's a nice day today.
It's a nice day.
Shining.
And no snow.
No snow.
So a plus. Also, of course, Kristina Lew, our radio show producer who pulls this radio show together every week, going toward our, I can't even believe it. Is it our 12th year? We're
currently in our 12th year, yes.
We're in our 12th year of this radio show. Amazing. And of course, Dan Cox, who just does everything for this radio show, and we're so grateful toward. So we have another wonderful guest, and we're so grateful to have Dr. Jessica Louie, who is a surgeon. Hi, welcome, and you're joining us today, and you're you've got a lot of things going on. Currently, you're an assistant professor in surgery at the Donald and Barbara Zucker School of Medicine over at Hofstra, Northwell. You also have your patient office at Northwell Health Physician Partners Surgery at Glen Cove. So we're looking forward to hearing a lot about what you do, and also a lot of advice. I mean, you really seem to be a true advocate, and you do love teaching. I was reading this wonderful email you sent us. So we'd love to hear a little background on you, Jessica. And again, welcome, and thank you for taking the time out to join us here.
No, thank you so much. So I am born and raised in Queens, New York. So I lived around the St. John's area. Then I went to high school in Brooklyn Tech, went to Stony Brook for college, University of Vermont for medical school. And then I headed to Charleston Area Medical Center in West Virginia, where I had my residency training. And here I am at Northwell. When I was pre-med, I actually used to shadow and I used to volunteer at North Shore University Hospital. So I've always been a Northwell fan, and I've always kind of seen it from the very beginning, and sort of even the little things and how the system kind of works. So now I'm a general surgeon, and coming from Charleston Area Medical Center, there were a lot of very sick patients, and a lot of the specialties were a little bit more blurred. So I felt like I had a wide net of skill sets that I've learned. So, thyroid, parathyroid, colonoscopies, robotic surgery, hernia surgery, colon resections, and all of that sort. So I was very excited to come back to the city and kind of serve the community that I grew up in. And I've had really great support in Northwell. I feel like, although I'm at Glen Cove Hospital, which is more of a community feel, I still feel like I have the resources to all of the different specialties and other just support, mentorship from all the different hospitals. And I feel like my patients, as an extension of that, get that as well.
Dr. Louie, I want to if you could just kind of not differentiate, but what is a general surgeon compared to another specialty in surgery? Okay.
So a general surgeon, you think of classic cases such as, gallbladder disease, so laparoscopic cholecystectomies, or lumps and bumps sometimes, there's a concerning lesion that you want to remove, like there's, bread and butter, you come in diverticulitis, you need an emergency surgery to control the infection. We do appendix, of course, that sort of thing. Hernias, those are a lot of the bread and butter, but it really kind of depends on your training and sort of, what you've been exposed with in your general surgery residency, of course. Sometimes there are more extensive lesions, let's say in colon cancer, for example, that are more, towards the rectum and that sort of thing. So sometimes you want a colorectal surgeon to kind of assist in the procedure. Plastic surgery, for example, breast reduction, you know, breast implants and that sort of thing would be a separate kind of field.
Right.
You know, ENT, obviously, you know, some of the tonsils and that sort of thing. Everybody has their different specialty. So, and honestly, sometimes it's blurred. For example, if you have biliary disease, which is kind of gallbladder related, but the stones, you know, they get stuck sometimes. Some of the pathology includes that. Then you move into something that's not even surgical. Sometimes you might need a GI doctor to help, you know, unblock some of the blockages before a surgeon steps in. Or if there's other kind of anatomy that's different, for example, certain types of cysts and that sort of thing, it may require not just a general surgeon, but maybe a hepatobiliary or an oncologic surgeon. So, you know, it's all about kind of learning where there's a certain boundary of where, okay, it's starting to get a little bit more difficult, then you ask for help and you kind of work together. So, you know, generally when you go to a hospital, you'll almost have like a PCP or a primary care physician in the hospital, which is the hospitalist, who will kind of see your whole presentation and see when it's appropriate to get certain specialists involved. And sometimes even then, there's a next step where the specialist will then say, okay, this is a little out of the realm of general surgery. Maybe I want to get somebody else involved. So I think we kind of talked about it off screen, but a lot of the times in the hospital, I know it's very frustrating. Sometimes it feels like, why is nobody talking to anybody? You know, why is everybody asking me the same questions? But it's important to kind of be almost as thorough each time when you're answering those questions, because although it seems like, oh, everybody should be on the same team, sometimes they're completely different. And this is the first time that this specialist is hearing your story, and they might offer different perspectives or might be thinking about your pathology in a different way.
Right.
And so,
yeah, that was one of the questions I had for you, because you did talk about, which is, you know, I think everybody on the layman's end who is with, you know, is, I don't want to say especially an older patient, but a lot of times older patients have a lot more things going on. Right. So it's constant, you know, different specialties coming in, and it can be frustrating to the patient. Right. But, you know, what you're saying is so important, that it's not the same doctor sending different people in. It's a lot of people trying to work together and getting the story the same and all that. So that's a really good point, because it can be frustrating, you know, especially if you're visiting someone and like 3 people come in, and that seems to be kind of, you know, a common, I want to say, complaint is, why does everybody keep asking me the same questions?
Right.
Well, I think one of the biggest things, frankly, I've had a lot of experience with is who's in charge. You know, I'm here, I'm in the hospital. I had the same internist for 25 years, and now I'm in the hospital. That internist is not involved. I now have a doctor who doesn't know me from Adam, and that's the primary care physician, what the term you used, but you don't always know who that is. You know, how do you how do you manage that as a patient who finally you are in the hospital? We're assuming that you went through all kinds of stuff to get there, but then you get into this loop where different doctors come in and you try to pull it all together, and it's very difficult. What's your suggestion in terms of how to kind of manage that, if you will?
Right. I mean, it is pretty frustrating. I mean, it would make sense, obviously, if the doctor that knew you most was able to follow you through, you know, outpatient, inpatient. But if you think about it, as doctors, we've had all this training, and, you know, we have, I guess, sort of this tool set to kind of help people. But the thing is, we can only be in so many places at once. And so, you know, while you see your primary care doctor in the outpatient setting, you know, they're over there helping as many patients that are like you in the outpatient setting in that day. So they have a certain schedule, and they have to be, you know, 9 to 5 or whatever it is, and see X number of patients. They can't, you know, feasibly kind of say, oh, you know, so-and-so is in the hospital. If you think about it, out of the 20 patients that they see in a day or more, I don't know how many, think of how many could possibly be in the hospital or in an acute setting. And so just kind of try to empathize with them from that perspective. It's not that they don't care. Obviously, when there is an opportunity to do so, for example, at Glen Cove, we're kind of a smaller community hospital. A lot of the times there is that overlap where, you know, there's a patient that's in for an acute issue that perhaps they were sent in by their primary care physician, and it's nice when they have time, they do stop by, and I like seeing that at Glen Cove. But sometimes, depending on how busy it is, it's not possible always to do that. Getting back to your crux of your question, though, I think maybe, although it's not your person or your primary care physician, start making those relationships. Sometimes if you stay in the hospital, it might be for a whole week. And it's actually kind of amazing to me how quickly you can bond with a person, especially in the most vulnerable times. So I think it's important to kind of communicate and be vulnerable, give the information that's important, and hopefully in the hospital, at least, that hospitalist or, the person who you're admitted under should be your go-to person. And then hopefully that person can direct your questions appropriately to the different specialties and that sort of thing.
So you basically, what I think I'm hearing is that it would be good to establish who is the primary care physician in the hospital and use that person as your focal point, as opposed to trying to work with the cardiologist, the this, the that, the whatever. And it's difficult then because you have to track different people down. You don't know when you're going to get to talk to them. So I guess, can you, like, would most primary care physicians be open to the fact that, you are who I'm going to talk to? And how do I reach you? Can I reach you easily?
Are you talking about the primary care physician,
the person in the hospital?
In the hospital. Yeah, I think so. They're very busy. A lot of times they see potentially patients on the same floor or, clustered, so they should be available. And, you got to remember there's also, if they are, not available, sometimes there's a lot of mid-level providers like nurse practitioners, PAs, residents. You can use them as an important tool as well. And that kind of adds on to that same thing that we were talking about with multiple questions. Unfortunately, or fortunately, sometimes there are, even within one specialty, you'll have multiple people asking the same thing. But again, everybody ultimately is just trying to help you, and you can use them all as resources. So, if they're asking you questions, maybe you can ask them some questions back and get some information.
We're making an assumption here that you are able to communicate with the people around you. Some people are not in good shape and they can't communicate.
I know. That's
so now you get into a different scenario, I think, where the patient needs a representative actually who does the communicating for them. You mentioned your parents, and I read that you speak Mandarin and Chinese. There's an additional issue that comes up a lot of times. My parents were immigrants, and I was the spokesperson at like 18 years old with doctors. There's a language barrier in some cases, which compounds the problem even more. So maybe, frankly, you have to look for doctors who speak your language.
Yeah, I mean, ideally, that would be great. I know that that's not always available, but, there's always translator services. And sometimes maybe even having like a pen and pad available and just at least learning, like, I don't speak English, I speak this. And then this way kind of emphasizing that I can't communicate like this, can you please get an interpreter on the line or something? That would be helpful. But I do think that, yes, that's an important point. There's, even with language barriers, there's also cultural barriers and things like that. So it's nice to be able to have someone who could at least speak your language, but it's not always.
I mean, it's complicated. I empathize. And most,
I do empathize.
A lot of people have different personalities. Some don't complain. Some complain every 3 seconds. And
sometimes, even hard of hearing, right? So if you
that's
need
a big
to
one.
Take the time to write it down and just say, please, I'm hard of hearing. Can we write instead? And that's totally fine. Sometimes it's not that the provider is not willing to do it. They just don't know that that's what you prefer. So maybe just communicate what you prefer. And then generally, I would think providers would try to, facilitate that.
I do think, going back to what Otto was saying too, there's a big difference between being a patient in a hospital when you're admitted for a planned procedure or for observation, and then if you are taken by ambulance, you may not be in a hospital that maybe is in your portal or in your area or where your primary care physician is. So, I mean, there's a lot of reasons I think why it's complicated. It's no, but no one wants to be there. I mean, as a patient for sure. But there's a lot of reasons why I think those kinds of things happen. But it's always good. Like with Project Independence, we have we have this pamphlet where we kind of it's all about planning for anything that could happen down the road, who to contact, in the middle of the night, your doctors. It just has it's like your entire life in a book. So at any time you can kind of give it to somebody else so they know what's going on. Share it with
circle of support.
Circle of support, right?
Right.
So it's not fun being a patient, that's for sure. But I love what you wrote in this email. You wrote that you have a passion for helping patients understand all aspects of their care to better advocate for themselves and navigate the system. I mean, the system just gets more and more complicated, and it's not necessarily because it's different complications. It's just that it changes so frequently, one day to the next, 1 year to the next. We're always having to update our, the Medicare and that kind of a thing. What's some of the best advice? How do we become better advocates for ourselves or for our family member?
So, I mean, I think knowledge is power, and just sort of, I know everybody has different personalities. Some people are more introverted, but I think it's important to ask questions. So for example, when I was training, obviously the insurance says all preventative medicine should be nothing out of pocket. It's all covered. But I guess I didn't read, or I didn't, I would think of myself as educated, but apparently there's different tiers to, to insurance. And so I went to a doctor that somebody recommended, and then all I did was get a checkup and regular blood work. I'm relatively healthy. And then I came back with a $700 bill, and I was super confused. I didn't know what was going on. I looked into it, and they said, oh, it's because this doctor's in network, but they're tier 2. And so, because you have this high deductible, you have to pay all this money. And I was like, oh my goodness. And it kind of broke my heart. Okay, never mind. It looks like we have.
We're going to take a quick break, but we'll definitely come back to that, because that is a very common situation where, does the doctor, does the hospital, do they take your insurance? So we'll be right back after a quick break. We're speaking with Dr. Jessica Louie from Northwell. She's a general surgeon. You're listening to Project Independence in You, and we will be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
And welcome back to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. I'm Rebecca Miller, along with Otto Lohse, Kristina Lew, and Dan Cox. We're speaking with Dr. Jessica Louie. Dr. Louie, before break, I recognized something that you had, that I had, where I think we all have, especially in the healthcare field, is this aha moment. It happened to you, that kind of a thing happened to me too, where I was like, wait a minute, something very different happened. I worked for a very busy practice many, many years ago, and the doctor was seeing a patient, thorough exam, older woman, in her 80s, came in, he gave her a lot of referrals. Back then we're still writing things out, scripts. She came to the counter to check out, and she walked out. She had referrals to see a podiatrist, a cardiologist, to get some testing done, some prescriptions, to pick up meds, some changes in her meds. She's, in her early 80s, and she walked out of the office and threw everything in the garbage. So she just, where do you start? How do you start? And I mean, I saw it, so I sent someone out after her, and we brought her back in, and we kind of, it kind of was like an aha moment, like, wow, she's overwhelmed. Let's explain to her how she can get it done. She also had a cab waiting, so it was like, and you having that experience of this huge bill, like, aha, there's advocacy that has to be done. And I'm wondering if that was a moment for you, like that aha moment I had. I was like, wow, there is just, it's overwhelming a lot, this system. So
Right.
To get back to what you were saying, when you had that aha moment, I saw your face, like, it's a lot of money when you're younger or you're in med school or wherever you're at. So just wondering if that was something that was like an aha moment for you.
Right. What I was saying before the break was that, as a healthy young person, I was just trying to check off boxes like, oh, I haven't seen a primary care doctor in forever. The insurance covers it. And they claim that if it's preventative medicine, it's all free. So I asked somebody, who do you recommend as a primary care doctor? And I go to see that person. I had a great interaction. I, got my labs. And then I get this bill in the mail, and it's like $700, and I didn't have anything extra. It was literally just cholesterol, all the blood work that you would expect. And I thought to myself, wow, like I didn't read things properly. It looks like, although this person is, when you ask, is this person in network? Yes, they're in network, but apparently there are tiers sometimes. So if you're tier 2, then there still is something out of pocket, especially if you have a high deductible plan and that sort of thing. So it's very complicated, even for myself. And that's why we work as a village. There's somebody who is more savvy about the insurance. I'm more savvy about the surgical aspects of things. But so I think it's important when you go to a physician, as much as you want to get your care, you want to make sure that you are not, you're going to a place that covers, or who has insurance. I mean, that your insurance covers, so that you're not stuck with the bill. Or, if you still choose to go to this provider, at least prepare in your mind, so perhaps, before starting, asking the nurse to see, or the secretary to kind of look things up, I think would be helpful.
Because, in hospitals too, you can see different doctors or different specialists, or people are coming in and, they may not necessarily all be on your plan. So, there's so much to have to understand in terms of that, and we've all had experiences in the field where, we can see where there's like a missing link, or, how do we help this woman who, she needs advocacy, and you're like, well, here you are a doctor, and you're, in that situation, you didn't read it carefully. So now you're you learned, and you're advocating for people to just be ask a lot of questions, A lot of times people just, they don't want to be bothered. They don't want to ask questions. I think questions are really the best way. Write them down, so much of that stuff is, even I have to write stuff down. And I know Otto and Kristina love lists. So lists are good too. Very list oriented people.
Well, like I've said, I'm sorry, but I've said on this show a lot of times, if you don't ask questions when you go to the doctor, you might as well go to a veterinarian who takes care of donkeys or elephants or whatever, because how does a doctor know anything if you don't tell them? They don't. They're not mind readers, unless it's an obvious thing, like you're bleeding from your neck, or But otherwise, how do you know? The basic question that we started with, and you mentioned at the beginning of the show, Dr. Louie, that your parents were asking you, why should they go to the doctor? I think that's the first question. Why are you going to the doctor? Is this a specific issue, a checkup, a follow-up? Are you going to a specialist? Are you going to a surgeon? And why are you going? And then after you figure out why you're going, then you got to be prepared for the visit with all kinds of stuff. Think it through. Write things down, make a list, have all your meds available in a list. And, it seems like common sense, but it's not.
It can be confusing because sometimes, a visit can seem simple, but that's sometimes because it's surveillance for, a cancer that you had prior or something. But sometimes it's very subtle, but some of these questions that we're asking is to look for red flags for recurrence and that sort of thing. And no news is good news sometimes. So sometimes if you check out and, oh, my doctor didn't do anything, why am I paying this copay to go see this doctor or whatever it is? If they're not doing anything, I don't need to go to this thing. I feel fine. And sometimes just feeling fine isn't enough necessarily. And so sometimes asking questions and say, you can even be frank with your doctor. I love it when my patients are honest with me and like, oh, well, it doesn't seem like we're doing anything. Like, why do I have to keep coming back, and not to be rude or anything, but, and then maybe they can explain, it's generally, at the beginning, we have you come back at 3 months, and then at 6 months, at the 6 month mark, we might even do imaging. So although we didn't do anything now, it doesn't mean that, the next visit we won't do anything. So I think it's just sometimes there's that disconnect with regards to why, and maybe us as providers need to do a better job of explaining. I mean, it's hard to say, but nonetheless, it's important to ask questions, like Otto was saying.
One of the things that I like to do is I ask the doctor for a script for lab tests before I go to the doctor, so we can talk about the results when I'm at the doctor, as opposed to going to the doctor and then they give you the script to go for the test, and then you have to have a follow-up of some kind.
Right.
It seems pretty basic to me that you should get that before, if it's just a normal checkup type of thing, or maybe if it's a problem that they're following up on that you had before, and you really have to do this, but I, as the patient, have many times been the one who brings up, I'd like to have the script now so I can have the results when I go to the appointment 3 weeks from now.
That's pretty smart. I mean, it's good to be efficient, of course. I think part of the reason why for the checkups that they don't is sometimes, like I said, it's not always cookie cutter. Everybody comes in for a primary care visit or for a checkup or a yearly exam, and they all get the same lab. Some people, based on their history, have other ones. So sometimes, depending on your interview, they might want to add other tests. But that's a good point. I mean, if you ever have a question or a suggestion, sometimes that's helpful. So generally, I think most physicians are happy to hear and try to accommodate.
Now, people who come to you, basically, they're not going to you directly, I would say, right? They're not just going through the yellow pages and saying, let me find a surgeon. You either you get people who have gone into the hospital, or a primary care doctor has said.
Generally, that's the case. I think there are some people who might look me up and then come to me, but usually it's a referral-based thing. And getting back to your point about being prepared for the visits, sometimes, depending on what hospital that you go to, it might not even be affiliated with, let's say our system. And so I've heard this a lot where people say, well, isn't it in the system? Like, why can't you guys look it up? And yes, sometimes we can. I do my homework if I can, and I see a patient's coming in for something, or they've, come from the ER. I can look at the images ahead of time and then talk to them about it, or sometimes even show them in the office. However, sometimes if it's like a completely different system, we don't have access to that. So if you have been hospitalized for a long period of time, let's say you've had surgeries before, or you've had imaging, sometimes on discharge, it might be important for you to ask, hey, is it possible for me to get a copy of the operative report? Because as surgeons, for example, we want to know, because we weren't in there, we want to know, what happened there. What did they actually do? Because sometimes it's easier as surgeons to say, oh, generally we did this, but there might be little nuances that a surgeon to surgeon reading an operative report would get more information from. And then, sometimes, although you have a report, to me, I always look at all the images myself, because sometimes you can pick up certain things. And sometimes when speaking with patients and you get a little bit more idea, like, my pain is more over here, then you can kind of look at the image from a different perspective. So for me personally, not only do I like the report on paper, which is helpful, I do actually like to look at the images. So sometimes you can ask medical records to print a CD copy of it that you can bring with you to the appointment, and then your surgeon or your physician can look at the images if they're interested. Not all people will necessarily need that information, but at least you're prepared.
Well, yeah, generally I find I like my chart which I think Northwell probably uses my chart as well. And that makes life much easier when you get to the doctor's office, like not to a hospital necessarily, but to the doctor's office. You don't have to sit in the lobby under pressure filling out a lot of forms. You can do that in advance. Or I've had people say, okay, I'm going next week or 2 weeks, whatever, send me the forms. If you're not one who is computer literate or can go on my chart. But the point I'm getting at is that you can take some of the pressure off of visiting a doctor, like while you're waiting in the waiting room and with a clipboard and trying to remember what meds you took and when did you have your COVID shot and when did you have the, your stent put in and whatever, all the other things. You can have all that done ahead of time at a nice leisurely pace.
Yeah. Oh, Otto, if all patients were like you,
I know. I was just thinking to myself, like, oh, he seems like a great patient.
But this all comes from hard experience. Like I said earlier, I started when I was like 18 years old with my own parents. And then, my first wife was sick for a long time, and that required a lot of communicating and hard life experience, if you will. And it's not the system's not perfect. Are we not perfect? All right.
We're not.
It's like one of the things that frustrates me. I see people, I used to travel a lot, and people in the airport will go up to somebody at the counter who has absolutely nothing to do with nothing, and they start screaming at them about why the plane is late. Well, there happens to be a thunderstorm and a blizzard with 28 inches of snow and whatever, which that person had nothing to do with. And that happens in your world also. People go off onto somebody who has absolutely nothing to do with anything. And I guess that all comes from experience, and try to understand the other side, of the equation. People who work in the hospital, like you, are trying to do the best they can. Now, reality, in my opinion, is sometimes they're understaffed. They don't have enough people to go around. That's the way it is. What can you do about that? Work around it, But anyhow, that's pontificating at the moment. So
no, that's great.
I have a question, kind of backing up just a little bit, because something that I'm kind of interested in, and I watch on some of the hospital shows that I watch, robotic surgery. So, I mean, it's not like a robot's coming in and doing the surgery and you guys are all standing there.
No.
You kind of control that. But how do you feel as a surgeon, like to use robotics to rely on that? Just kind of your overall take and experience and background with it.
It's a little bit of a misconception. It's not like a robot is like doing it on its own by any means. I think of it more as like a tool, essentially. So you start off the case basically like laparoscopic surgery, because you have to dock the arm, so to speak. So you create your incisions, you put in your ports, and then basically once everything's set up, there's always people at the actual at the patient's bedside. And so there's trained professionals in robotic surgery that kind of assist the surgeon. So the surgeon then scrubs out, goes to this console, and then it can control the arms. But obviously, the arms can be switched out with different tools. There's like, cutting tools and like stapling tools, depending on what is necessary. And so basically the console allows us to control these things, but even the tools, what's special about robotic surgery is that the ports kind of stay a little bit more stable than, I guess, the laparoscopic. And so you can get more degrees of freedom, and you can kind of rotate your wrist in terms of your tools. So it's helpful in that way, but don't be alarmed. Nobody's like leaving the country and having, a robot kind of do your surgery. It's just better technology, essentially.
Can we relate that for a second to something like you mentioned appendicitis, that you have done that? Years ago, when somebody had appendicitis, it was like a couple of week deal before you recovered from the surgery. My grandson not long ago went in for appendicitis. He went in like 10 o'clock at night, and he was checked out the next morning at like 6 o'clock in the morning.
Right.
How did, what was different between what they used to do and what they do now with that kind of robotic surgery thing or laparoscopic, whatever it is.
Yeah, I think, well, I guess I'm trying to get a sense of time frame. I'm thinking maybe back in the day before laparoscopic surgery was an open surgery.
Yeah, I'm
so,
talking
like an
back.
incision like this. And so, generally when you have an open surgery, it's just going through more muscle and tissue. It just takes a little longer to kind of recover from that, as opposed to the smaller incisions with laparoscopic surgery. So I think that's the main thing. Because generally, when I talk to my patients, the things you have to go home generally are be able to, eat and drink, keep things down, hydrate yourself, be able to have good pain control with oral pain medications. And so I think maybe some of the barriers to that with the open surgery is that, you're still in pain. You can't really get up and move. And sometimes when you do open surgery too, anytime you touch the bowel, even if you don't cut it or anything, you can potentially get what's called an ileus, which doesn't mean anything bad. An ileus is basically like the bowel is not physically kinked off or anything, but it's just shocked. And it's like, I'm not moving. I'm not going to do the normal peristalsis movement that kind of moves things through. So if, you're not passing gas, meaning that there's no bowel function, then it's sort of like if you keep eating things, you'll potentially, vomit it back up and that sort of thing. And so I think that might be part of it. So if you have open surgery, you're more likely to develop things like that. And so if you don't have good bowel function yet, you can't get out of the hospital. Versus laparoscopic surgery, if it was not like a perforated appendicitis or something that would cause an ileus and you're doing relatively well, then generally you can go home earlier. And one other thing too is I always tell my patients, there's a fine balance between, staying in the hospital and going home, because of course I don't want to kick anybody out before they feel ready. But by that same token, sometimes, I do feel like even for my own parents, I would recommend going home if they check off a lot of the basics, things, if you're doing things that you can do at home in the hospital, sometimes it is better to go home because, there's other risks of infection and transmission of other diseases or, blood clots. If you think about it, you're in the hospital, you're more inclined to stay in bed and people will bring you your meds and all that stuff. Whereas at home, you're like, oh, I guess I can walk over there and get a glass of water or something. It's just better to stay active. It'll prevent pneumonias and prevents blood clots and that sort of thing.
Okay, well, perfect time to take a quick break. You're listening to Project Independence and You Community Talk Radio on 88.1 FM and WCWP.org. We will be right back talking with Dr. Jessica Louie.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
And welcome back to Project Independence and You Community Talk Radio on 88.1 FM and WCWP.org. I'm Rebecca Miller along with Otto Lohse, Kristina Lew, and Dan Cox. And today we are speaking with Dr. Jessica Louie and just learning a lot about general surgery, also Glen Cove Hospital, a little bit about where you're an assistant professor. And before break, we were talking a little bit about robotics and the way surgeries are and leaving early. And I'm going to just talk a little bit about an experience I had just in terms of advancements and what it meant. I had, in 2018, I had AV nodal supraventricular tachycardia, and I had to have a cardiac ablation. I never knew anything about it. It came on suddenly. Mm-hmm. I went in, I had it was in the procedure room, not out, completely awake, 40 minutes in and out. They did their little tests, they zapped wherever they had to. There's a million monitors. It's over. I go into recovery. I'm home, a few hours later. And, it took like a week before I was able to get back to normal. The only thing I had was just a little burning feeling in there. Mm-hmm. But, 30 or 25, 30 years ago, that procedure where they just go in with a catheter, talk about advancements, I think was an open heart procedure, and you're going in there blind, trying to find where this trigger is, where this whole pathway is, this electrical pathway. So, I mean, it was just like amazing. When I first heard that I had to have this procedure, I was like, what? What is this? And I mean, advancements are just amazing. And I think because also it makes recovery a lot easier when you're not doing these, these things that we learn. So yeah, advancements are great. And I can't imagine that with this kind of, I don't want to say minor condition that I had, people having to go in if they chose to have this major procedure, years and years ago. But I know, anyway, Otto.
Well, I'm proud of you that you were able to remember that procedure's name.
Yes.
I want you to spell it for me.
I researched it in and out, 47 different ways. And, I was lucky enough to have a surgeon whose daughter-in-law had the same exact name as me. So he said, "You are going to be fine, don't worry." But I actually had it at St. Francis, and they're wonderful. And it was, a complete, professional experience. But yeah.
We talked during the break, which I'm not supposed to do, but I did, about the fact that, to me at least, most of the experiences I've been involved with, the surgery was really a no-brainer. Just you're laying there, you get conked out, or you get whatever, so you don't feel anything, and then you wake up. And in some cases, that's fine. It's good. It works out great. But in some other cases, you may wind up with a healing process that involves a lot of pain, and pain management becomes frustrating and really a big deal. And one of the frustrations is that's the latter part of the process, and it's difficult to get people sometimes to understand that you really do have a lot of pain, and how do you manage this? And unfortunately, I don't think it's an exact science. And so the pain keeps going on. What's your feeling about like the healing process and the pain management end of things after you go through whatever surgery you might have?
Right. I mean, pain is very subjective, of course, but it's also very individualized because each patient has undergone different experiences. Some people, it's not even about thinking, oh, this person had an addiction or this person's abusing the system. No, sometimes it's just a matter of the person's body. Let's say they've undergone lots of surgeries before, or they've had to have narcotics for chronic reasons. And so each person's sort of tolerance is different. So, I think it's important, to work with your surgeon and kind of figure out, there's usually an acute regimen. And then if after a certain amount of time, it starts to be longer than expected, sometimes it might be helpful to get a pain specialist involved, somebody to follow you in the outpatient setting and that sort of thing. Generally, well, also another thing to think about too is, if there's persistent pain beyond the amount of time that one would expect for this type of surgery, it's important to kind of be on the lookout for other issues, like maybe you're developing an infection or some kind of complication. Not all the time, but it's just something to keep in the back of your mind. So make sure you are aware of your body and sort of little changes like, hey, am I developing redness at the site, or some tightness or swelling or drainage, and make sure that you communicate that with your provider.
Now, typically that should be done with the surgeon, with the person who did the surgery.
Typically.
Right. And unless you as the surgeon say, I think you should get involved with a pain specialist. I'm just thinking, like, how does the flow go?
Yeah, usually in the hospital, you'll work with the surgeon, and then I guess have a pain regimen to go home with. But let's say usually you'll see your surgeon as an outpatient in about like a couple of weeks. And then at that time, we'll kind of reassess. Generally, I would think that the normal amount of narcotics that they prescribe would be enough to cover up until then, and you shouldn't be needing any more. But I think it's an individualized discussion, and you explaining kind of what the situation is, and then them then deciding, whether it's something that they can just give you a few more pills and then you'll get over it, or is it something that we need to get a pain specialist involved or use even multimodal pain therapy. And what I mean by multimodal pain therapy is that narcotics are not always the answer, although they are very helpful in the acute phase. Sometimes even, over-the-counter Tylenol and Motrin, sometimes you can alternate the two of them, and kind of get a decent effect as well.
Yeah, because I've known people who were put on oxycodone and it didn't do anything. They still had pain.
Right.
And, and me, if you give me one Advil, the pain goes away. I mean, I'm lucky, thank God.
Right. And depending
everybody has, as you pointed out, I think definitely a very big difference in range of pain.
And
it's not like people make it up. I mean, they have pain.
Of course. Like certain surgeries, if you're doing like a big midline incision and you have a lot of muscles there, sometimes muscle spasms can cause the pain. And so, I personally sometimes like muscle relaxants if that's the case. Obviously, you have to balance that with, because it can have a little bit of a sedating effect to that with the narcotics. So you'll have to time things a certain way so that you're not getting everything at once. But sometimes the spasms themselves are what's causing the pain. So if you can, relieve that, then it might not be as painful. Or even heat therapy. I personally love heating pads, obviously being very careful with them because you can burn yourself if you sleep with them or something. So just being very mindful and careful. But, there's other modalities too to help facilitate pain control.
That's an interesting one. You said heat. That heat versus cold is like one of the major confusions in the world. One person tells you, oh, put ice packs on, and then somebody comes along and says, put heat on it.
I guess it kind of depends, like let's say I'm not an orthopedic specialist or anything, but I'm saying, let's say if somebody had a twisted ankle or something, initially I would think you would put some ice on it to kind of relieve the swelling. And then later after a while, maybe put some heat on to help kind of get blood flow in the area and heal it over time. But sometimes it's individualized, what feels good to you.
So since most of our listeners are older, going to be Project Independence members or people in the town, there's a question also I have, like we were talking about in the very beginning of the show, how people get frustrated when so many different doctors and nurses and people that come in for physical to ask the same questions, and you have that feeling, oh gee, why didn't they tell you that? But it really makes sense. You have people that have to work together and they need the information, and things may actually change a little bit with you, because I think that happens a lot. People will be like, well, you know what, it doesn't hurt as bad now, but when I first came in, so I mean, there are different levels. So that was really good. So from the patient's perspective, they're told that they need to have a surgery or a procedure, and booking it that day. What I'm getting at is a second opinion. A lot of people want a second opinion, and I think even most doctors and surgeons and their families, you'd want to get a second opinion. So it's good to get a second opinion. And I know sometimes people feel like allegiance maybe to their doctor or to their surgeon, but it's really not about the doctor's feelings, because obviously they're going to say, definitely get a second opinion. It's helpful to that doctor as well to concur, or maybe they'd see something else. So what are your vibes on the second opinion?
I definitely don't take offense, because ultimately, doctors go into this, I would think, to help people, and they care about their patients. And so, there's so many different ways to kind of approach a certain problem. And sometimes a problem is not straightforward, right? It's not just like, oh, nail on the hammer, just go at it. It's sometimes there's different things to consider. And so while one person might have an opinion of something, like a certain approach, sometimes it's helpful, like you said, to kind of get reassurance that, the other surgeon said the exact same thing. So sometimes, they agree, then you'll say, I'm going to do the procedure with the first surgeon, just wanted to make sure that it was the right choice. And so I don't think that most people get offended per se. I think, at the end of the day, especially sometimes I'll be talking not just to the patient, but to their loved ones, their daughters, people who want to advocate for the patient. And, I think, it's helpful to let everybody feel like this is the right choice. So if it means
the
getting
flip
more
side of
information,
that,
then it's good.
but the flip side of that is, how does the second doctor feel about giving the second opinion? Like, it's like you're going to them as an afterthought. It's not like, I'm not going to do business with you kind of thing. How do you feel about when people come to you for the second opinion?
I mean, at the end of the day, I think it's just, I don't really think so much about first or second opinion, I guess. Like when someone comes to me to a problem, I just kind of answer the question or try to help them. I think it's like a logistic, I happen to know that I'm a second opinion, but I don't really like internalize it so much, I suppose, or like judge it in a certain way. I think I just treat everybody kind of the same, if that makes sense. I don't know if everybody does, but I would think, it's just, how can I help this person in a way?
And that situation, is about the patient. So, if you start, I don't want to say you don't want to ever worry about the doctor's feelings. Because in a sense, we're paying the doctor for a service. So that's part of the problem, I think, Otto, with a lot of, I want to say the older generation, and this feeling they don't want to be a problem. They don't want to, but to kind of, it's like I think any surgeon would be used to that, especially if you're in the same field, the same area. You might even get, your current doctor might recommend another surgeon, that you think is good, So as the patient, it's important for them not to worry about that and to advocate for themselves, to make sure they're feeling quite comfortable. Obviously, if you're coming into an emergency room and you need surgery, you're going to have, you're not going to say, hold on a minute while you.
Right. And I think it's important. To me, it's an honor and a privilege to be able to have that kind of mutual respect from the beginning. But I understand that not everyone has that kind of connection right away. So I think it's important. And sometimes I would think, for, let's say, the initial surgeon, if things didn't kind of vibe well, or they felt like, I want to get a second opinion, maybe it's better, right? Maybe it's better for that patient to find a physician that they're comfortable with, that they don't go into the surgery with reservations, or, I don't know if that was the right choice. You want to make sure that you had all the information at your fingertips to be able to make sure that you made the best decision that you could. Obviously, no one has a crystal ball to know for sure, but I think it's important to have that relationship.
You used the words mutual respect, and I jotted them down. I was going to bring that up, and I think that's true. It's true in all relationships with people, really. You have to have a mutual respect. If you don't have a relationship, in my opinion. And trust. You need trust on both sides.
Right.
Yeah, it's great. We have a wonderful partnership with Northwell. Our Department of Services for the Aging, Project Independence, we even subcontract for nursing services. So our nurses, and so many of our guests are from Northwell and other systems. Kristina really gets the full gamut, and it's great. I don't know, have we ever had a general surgeon on the show before, Kristina? This is another one.
I feel so special. Thank you for having me.
Yes, but I love the fact. You're a general surgeon, and you're also a professor, and is how popular is the surgery field these days on Long Island, since you're kind of on our home island teaching?
How say it again?
How popular is surgery? Is it a big department at Hofstra?
Yeah, of course. It's across all of the different hospitals, really. And I've been involved with teaching with the medical students as well, earlier in their years with knot tying and that sort of thing, and suturing. But I think it's important to kind of set good examples, even at the very beginning of their training. So I'm involved with teaching not only the medical students but the residents, and there's residents now that rotate through Glen Cove, and it's very fulfilling to kind of see their growth and sort of be able to be a mentor to them, essentially, through not even just the medical logistics of like, how do I do this, but even just how to navigate the system in a different way. And
we are coming kind of toward the end of this hour. I just wanted to ask, is there a way people could get in touch with you or with your practice? Is there a website, a phone number that you prefer?
Yes, I don't have it on hand, but if you Google Jessica Louie, MD, generally it'll pop up. I think the first link will be the Northwell link, and it has my office number that you can call, and they can put you in touch with me if you needed to see me in the office setting for a medical reason, or even for, mentorship or anything like that.
And also our listeners can always call 311 or 516-869-6311, and we will have Dr. Louie's contact information. So we want to thank you so much for taking an hour out of your day to talk to us and to our Project Independence listeners. It was really great information, and I'm sure Kristina will book you back again in the future. Again, we just want to thank you so much for joining us.
It was a pleasure. Thank you for doing what you do for the community.